Great.
This meeting is being recorded.
Welcome and thank you for joining us today for the meeting of the New York City Health and Hospitals Finance Committee. Today's meeting is officially called to order. I would like to propose a motion to adopt the minutes of the Finance Committee meeting held on July 10th, 2023. I'll poll each member for their vote. Jose?
Yes.
Dr. Katz?
Yes.
Sally?
Yes.
Barbara? And I vote yes, so the motion is adopted. Our next is an action item for consideration. I think Chris or Ted, please read, please read the resolution into the record.
Sure. Maybe I'll slide over here so I can see a bit better. Hey, good morning. Chris Keeley with the Office of in Operations in Ambulatory Care and with the HERC program. Good morning. So for consideration, we are seeking authorizing the New York City Health and Hospitals Corporation to execute contracts with Aaron Security Incorporated, DBA Aaron Security, Garda World Security Corporation, DBA Garda World Security Services, Mulligan Security LLC, and SLS Co. Limited for security services and a not-to-exceed amount of $323,700,000 for a contract term of 1 year and 2 6-month renewal options exercisable at the discretion of the system. What we're looking to do here is to provide 24/7 security at HERC sites operated by New York City Health and Hospitals. Security is needed to ensure the safety of all guests, clients, and staff. At these locations, we've got 15 operating sites currently with more than 20,000 guests. What we're looking to do is to be able to have security guards help provide the safety for those guests as well as for our staff and anyone else who needs to be on site to provide service to those individuals. Currently, we're using 2 existing contracts. Aaron Arrow, which is an existing system-level contract that we've accessed for these purposes, and with Mulligan Security, which is an emergency authorization contract. Our historical spend here, we've paid out $28 million through August 2023 for Aaron and Arrow, and for Mulligan, we've paid out $1.8 million through August. Both contracts price staff on an hourly basis, plus limited expenses for line items such as radios or cars for our outdoor locations in particular. There's no ancillary costs here, and this RFP was done to competitively bid for these services and identify additional vendors that might be well suited to this work. We've done reference checks for the new vendors that we're seeking to move forward with, as well as you'll see, we seek to move forward with our two incumbents as well. All of the expenses will be covered by the HERC MOU with the mayor's office. So all of our expenses under this contract will be covered under that MOU. On the next slide, you'll see our minimum criteria here was 3 slides in business performing similar services for a multi-hospital system. And you'll notice at the bottom there, really what we're looking at is we're looking for relevant experience, importantly in homeless services, working with immigrant populations, working with asylum seekers. Along with the minimum criteria there, we're looking for MWBE status, utilization plan, or a waiver request, and $5 million in annual revenue for each of the last 3 years. For our substantive criteria, there's the 30% for relevant experience, as I said, and as noted at the bottom there. What we're really looking for there is providing security services in homeless shelters, transient settings, or working with the asylum seeker population. Other substantive criteria is 25% each for readiness to deploy and cost, and 10% each for cultural competency and MWBE. Our evaluation committee consisted of folks from ambulatory care, HERC operations, finance, as well as the Health and Hospitals Chief Security Officer and the Chief of Hospital Police. On the next slide, you'll see the overview of the procurement. In late June, the application to issue the request for proposals was approved by the CRC. July 7th, it was posted on the city record and sent directly to 7 vendors. A week later, the pre-proposal conference was held with 22 vendors attending. And then on July 28th was the deadline for proposals, at which point we received 12 proposals in. On August 10th, the evaluation committee debriefed and submitted final scores, seeking to move forward with the 4 highest rated proposers. As noted, that's Aaron, Garda World, Mulligan, and SLS Co. For our not to exceed cost analysis here, the projected spend was calculated based on the need for security services at 19 HERC sites. Currently, we're operating 15, but we know that this is a growth space, so we put in an additional 4 sites to help reflect the sort of unknown going into the future. The monthly estimates are based on existing staffing models at each of the HERC sites Each site has staffing models, for example, that might be different based on the site type, the facility layout, and fire safety requirements. So we operate sites that might be in a hotel, and that might look a little different than some of the sites you may have seen at the news on Randall's Island or at Creedmoor, some of those outdoor tent locations. So depending on the physical layout, we might need more or less because there might be a different number of points of ingress or egress at a building. There might be multiple floors where we want to be able to have guards rounding throughout a hotel. So depending on the layout of the facility, we need a different head count. The hourly rates for security staff are largely dictated by local labor law, and all aspects of the hourly rates were competitively evaluated as part of the RFP, and they're in line with current market conditions. On the next slide, you'll see for the 4 vendors here, the vendor diversity. The vendor diversity team at Health and Hospitals established a 30% goal on this contract. And you see here on the right side of the table, each of them met or exceeded that in their proposal. Garda-World at 31, Mulligan at 35, and Arrow and SLS both at 30%. And you see in the subcontracted scope of work, most of that is performed or would be reached through staffing. On the next slide, you'll see the vendor performance history. You see here for Arrow Security, satisfactory across the board with one note there in terms of improvements needed and improvements made. And that was that we saw a few instances where certain guards were leaving their post at the end of their shift before their relief coverage came in. We've been able to address that locally at the individual sites. It happened a few times. It's been addressed. So thankfully that needs improvement. The improvements have actually already been made. On the next with Mulligan Security, their performance to date has been satisfactory across the board, as you see there. So the request here is we are seeking approval to enter into a contract with Aaron Security, DBA Aaron Security Incorporated, DBA Aaron Security, Garda-World Security Corporation, DBA Garda-World Security Services, Mulligan Security, and SLS Co. Limited, to provide security service at a not-to-exceed amount of $323,700,000, with a contract start date of November 1st, 2023, with a term of 1 year and 2 6-month renewal options. As I said at the beginning, New York City Health and Hospitals security expenses will be covered by HERC MOU with the Mayor's Office. Thank you for your consideration.
Thank you, Chris. Questions?
You reported some negative trends with staffing. Is there any other information regarding why there may have been some issues there?
And I would even call them negative instances, where there were a few instances at a few locations where, across an operation this large, where you've got, maybe a dozen or 2 dozen security guards on 24 hours a day across 15 sites, there were some instances of individuals leaving their post at the end of their shift before the relief came. The gaps, as we looked into them, were a matter of, 5 minutes, 10 minutes, 15 minutes along those lines. It wasn't that they were going uncovered for hours. And what we did find was that the supervisors on site were managing it well. In terms of that person left, they were able to help provide swing coverage, bring somebody back in from a lunch break. They were able to have the supervisor go provide coverage as needed, things along those lines, so that there was not an actual gap in service and a gap in coverage. But we wouldn't want to see that sort of thing continue. We wouldn't want to see it turn into a trend, as you noted. But with those instances, we did see them handle it well.
Well, security is really important. The 570 minus 570 is what we were talking about here?
I'm sorry?
Is that the dollar amount we were looking at? That was,
For the not to exceed amount?
I'm looking at,
The other,
okay, the upper, okay. Security is very important in our hospitals.
It is, and at these locations where we're housing asylum seekers coming into New York City, they're going to be at the hotels, they're going to be at some of these, base camps like at Creedmoor that you may have seen on the news, or the Randall's Island tent where we're housing these asylum seekers. And what we do is have a very thorough security apparatus on site. And so, there's a badge like this that every one of our guests and every one of our staff has. Every time one of our guests or a staff member wants to come in or leave the location, they need to zap the QR code and make sure that only authorized people are on site. And the security is paramount at our locations.
It's just as high as any doctor or nurse being at the bedside.
I think so.
Yeah, thank you.
Sally?
I just had a couple of questions. When did we contract with Arrow and Mulligan?
So Arrow, and I won't have the timing on that, but if anyone from the procurement team may, but the Arrow Aaron contract was a pre-existing system level contract that was competitively bid some time ago that we accessed for these purposes. And then for,
How long ago was that? Do you have a sense of?
I think it was well over a year ago now. I'm not sure if anyone from procurement or legal might know, but
Okay.
it's well over a year ago is my understanding. And then, for Mulligan, that's been more recent. We wanted to diversify our security provision, right? We don't want to have sort of all of our eggs in one basket. The same reason why we have 4 vendors that we're going forward with on this RFP. That's not to say any of those 4 are guaranteed work. We're going to have operational discretion to provide work or to assign work to the different vendors based on what we think their strengths are, based on the service level that they provide. And so initially, when we were only tapping into that Arrow system level contract, they were sort of the only game in town for us on the Herc side. We needed to bring somebody else into the mix to have a little healthy competition in that space.
Right. And are the hourly rates you are paying these 2 firms consistent with their bids, or did they come in more aggressively for the RFP?
That is a great question, and that is something that we're very aggressively pushing on now. So there's a number of different roles that they might provide, so a supervisor versus a frontline security guard, for example. And between the 4 different vendors, they're all generally pretty competitive with each other, and one might have a slightly higher supervisor rate, one might have a slightly higher or lower frontline guard rate. And what we're able to do now with this competitive RFP is we're very aggressively working with the 4 vendors to bring down those numbers even further. Because in effect, what we can do, I should say, now that we would have, hopefully, if approved, what we would have is 4 vendors that we could work with. We could sort of say, hey, you're going to price yourself out of competition. The other ones that we're looking at, they're cheaper on the supervisors, they're cheaper on the front side, and we can help bring down the cost across the board.
And you're going to make assignments to the firms. And what type of criteria will you use in determining which firm you're going to use for what location?
Yeah. So a lot of it is what it has been, and we'll see how things evolve. But what it has been to date, it's largely based on operational capacity on that vendor side when we're looking to go live at a location. And so if we've got 2 new locations coming on over the next month, for example, if that were to be happening, probably what we'd look to do is assign 1 to one vendor and 1 to the other. Or in the future, if we're going to bring in a 3rd or 4th of the vendors, we might do the same, because we don't want one vendor stretched too thin.
Right.
Oftentimes what they're looking to do, or what they're needing to do, is recruit and hire new staff members. They need to go out and buy the uniforms. They need to go out and buy the rate. All of that sort of their HR on their back end, what we like to do is try to sort of spread the love a little bit so that each of the vendors can each bring their own capacity to the table.
Okay. And do all the vendors have the breadth of experience at different locations? Hotels, hospitals?
Yeah. So these 4 all have at least some level of experience in hospitals, and then what we were looking at there from the scoring criteria is we really leaned in on, do you have experience working with asylum seekers, transient populations, immigrant populations, homeless New Yorkers in particular? And that was a big driver. You see on the scoring criteria there, that was 30% of the score. So these ones do have relevant experience in this.
Okay, thank you.
Thank you.
Other questions? No. Just quickly, Chris, 2 things on Arrow. Will they still continue to be working on our system-wide contract, or are they transitioning over just to doing the HERC contract?
The intent here is to have no impact on the other pre-existing system-level contract. What we wanted to be able to do was sort of bring this work over into its own separate contract and sort of leave hospital police and that team to be able to manage Arrow Aaron as they would otherwise.
Okay, and the amount that we have on historical spend to them, that was just for HERC purposes, right?
Correct. What we have here for historical spend is just for HERC.
Okay, and then I believe there's going to be an update to the vendor diversity slide. Is that?
Yes, there is. And what we're going to be able to have there on the vendor diversity slide is we're going to be able to indicate where it says NYC, NYS. We're going to be able to provide additional level of detail. My understanding from Calicia is that'll be in the board packet for the full board meeting later this month.
Great. well, if there's no other, oh, yep, Sally.
Do our hospital police have sufficient resources to oversee these contracts? It's a lot of people. a lot
So
of-
for these contracts, we have been with the two incumbents that we've got, and the intent is to go forward managing them primarily through the HERC team. But what we're doing is working very, very closely with the hospital police team, especially on a go-forward basis. We've been able to hire a director of security on the HERC team that's going to be working very closely with his colleagues in the hospital police team, so that he's got the right level of support on that side of things.
Thank you.
Just one more question. Given that many of them may not be that familiar with hospital, are we comfortable with the level of orientation and, competence they have?
That's a great question, and that particular piece around the orientation of sort of working in these spaces. We've talked a little bit about the relevant experience of working in homeless shelters, working with asylum seekers, transient populations, and so they all do meet that criteria. But that orientation piece is something actually that we're putting a lot of time and effort into in terms of making sure that as they're onboarding their individual guards, that those guards are walking in with the right mindset, that they're getting the right training and understanding what it is that we're looking to do at these locations in terms of providing the best possible care for those individuals while they're in our care. We want to provide the best possible support, and
Would
so
you
that is
kindly-
one of the key things we're looking at is how to get better and better all the
Oh,
time
I'll
at
tell you
orienting
how.
them for it.
Would you kindly make sure they get a chance to be face to face with nurses, nurse leaders, for a little taste of what really goes on the units? Because if the nurses call them, they got to get there.
Understood.
All right.
Any other comments or questions? Well, thank you, as always. I know you guys are doing a great job here, so appreciate it. I will go ahead and call for a motion to approve the resolution.
So moved.
Um, Jose?
Yes.
Dr. Katz?
Yes.
Sally?
Yes.
Barbara? And I also vote yes. The resolution is approved, and we will move this forward to the full board. Thank you very much.
Thank you.
Next, on the agenda, we have a financial update, and I know we are running short on time, so there's a lot of great information here. It's been obviously challenging times that the team is managing. I think primarily we're reporting on fiscal year end 23, but then with a little bit of context for what we're facing going forward. So John, we may not be able to get to everything, but similar to audit, we will have it in the record, but if you could hit some of you and the team could hit some highlights, that would be great.
Yes, we'll go, we'll give you the abbreviated version, but I don't think we'll lose much here. So first, thank you for your time, bless you. As we reported earlier and on an accrual basis, I think the system is stable. We're working our way through COVID, right? There's a lot of transactions that are at play, but I think on balance, we're doing just fine. We closed the year with $746 million in the bank, 29 days cash on hand, which is pretty good for us. We're reporting here that our net budget variances, we missed the target by $48 million, which is, pretty much right on target. We're seeing, within the data, direct patient care receipts are flattening out, which is to be expected. And an increase, really, it's interesting kind of looking at, the performance of the outpatient ambulatory care, because visits there are up 8%, where I think we're pretty much flat on the inpatient side, maybe down a percentage. All the work, we continue to do on our financial initiatives is certainly, paying dividends. Our target was $675 million. We recorded $830 million, so we beat the target by about $150 million. And I would say in each one of these areas that we list down below, there's multiple different initiatives that are ongoing, and each is actually performing very well. We've raised the bar for next year, of course, and we'll talk about that the next time we get together. But I think we did very well in terms of closing out 23. We closed September with $950 million in the bank. That's 35 days. That's high for us. Working through some transactions with the health plans, and closed October with $700 million. So we've been doing fine. We'll see, just as part of our normal course of business, those balances will drop. But I think from where we're at this point in the year, we feel pretty comfortable. In terms of financial performance, maybe I'll skip, Selima, maybe we can do slides 6 and 7, because I think those are the ones that are
Okay, so this is our revenue variance at year end. Obviously, we performed very well, to John's point, when we looked at the strategic initiatives. We're ahead of target by 466 million. About 200 million of that is coming from inpatient and outpatient billing related revenue, in addition to about 90 million of appeals and settlements that were unanticipated. And then the balance is coming from excellent risk pool performance, primarily driven by Medicaid, PMPMs being higher than budgeted, as well as the enrollment being higher than target. Conversely, on the expense side, we do have an overage of 514 million in spending. Roughly half of that, 272 million, is driven by agency patient temp staffing coverage. Again, that variance is offset by PS surpluses, primarily in nursing. I think we all know the story there, and that we're moving in FY24 to our glide path, which I think will be talked about later in the slides. And then we have other discretionary spend that's over, partially driven by pharmaceutical and med surge supplies. And that number there is a combination of catching up on post-COVID payments from cash flow perspective, and then in addition to that, inflation and utilization increases.
The next slide, we probably skip over. We just like this slide, right?
I like it. I like all of this right now.
But yeah, I think it shows kind of the actual performance, which we like that perspective, plus
Yeah.
against how we budgeted. Moving on to rev cycle real quick. Margie, go through a couple.
Sure. I will quickly talk about our AR Days initiatives. We were working toward a target of 45 days in the AR for fiscal 23. We ended fiscal 23 just off the mark. It was a little bit higher than that, but have since achieved just that 45-day target and reset the goals for fiscal 24 at something lower than that. But it's important to note that the AR days, despite having missed target a little bit, they had declined by just about 13% since January. So we are definitely in the right trajectory. Can move the slide forward. In an effort to really make sure that we achieve our targets this year, we held an AR Days Summit, or actually two of them, with our CFOs and patient account directors with Revenue Cycle Services, really to identify those themes and areas that we can transition to a work plan. So you can read it. I don't have to read it for you. But basically, we're talking about training, team structure, optimizing what we're already doing, and making sure that we're putting the metrics in front of people and really pivoting quickly to new metrics as it becomes relevant, but working together collectively to really improve this metric.
In terms of our efforts to assist our patients who are Medicaid recipients with recertifying their coverage, with the reinstatement of the renewal requirements at the end of the public health emergency, we are tracking well compared to our financial plan. We're about 3 months into this effort, which we expect to be ongoing through really the course of the year. But compared to our financial plan assumptions, which assumed a decline of about 25% in membership associated with the reinstatement of the renewal requirements, we're actually doing quite well. We are currently beating these assumptions by somewhere around 3 to 5%. New York City is lagging a little bit behind the rest of the state, but Health and Hospitals is more or less on pace with the rest of New York City.
With the rest of the state or with the rest of New York City?
Sorry, with the rest of the state.
Okay.
And, you know, just to highlight, actually, the renewal rates that are shown on this slide have actually improved a little bit as of Friday report. So with the trickling in of some late renewals, we're actually at 80% for both Metro Plus and Health First for the June cohort. And we are at about 77 and 80% for the August cohort. So again, tracking quite well, and if not, beating some of those financial plan assumptions.
So Health First has gone from 65 to 80%?
Yes, yes.
Terrific, okay.
And individuals can continue to renew really through the end of the month following the month they're due for renewal, so that's why these numbers do tend to pick up.
Yeah, I think Health First and Metro Plus are both doing very well. And I'd say it's very much a collaborative effort, right? I think it makes a difference when you have provider-owned plans working together in this area. I think it puts us at a slight advantage. Managing risks, I can quickly go through those. We're good there. So most of these risks, obviously, we're always keeping track of, the pressures that we're under at health and hospitals. Most of these, I would say, are external in nature, but staff recruitment and retention, certainly something that most large healthcare systems are trying to address. The temp service costs, we mentioned a number of $272 million last year. We definitely have to get a handle on our usage of temp services, for nursing as well as non-nursing. Initially, maybe you should just spend a second here going through the slide in the all hands on deck initiative.
Sure. So, system-wide, we've had a meeting that we called All Hands on Deck, which is a collaboration between nursing leadership, HR leadership, and finance leadership, both locally and centrally. So, in that, we basically shared the glide path, which is how, what our, well, I should say, one showed the glide path to show our goal for the next 18 months overall. And then our nursing and HR leadership went through key components for recruitment, temp conversion, and retention of our staff so that we can get back to our to filling our vacancies that we've had, being able to get our models and things like that for our RN staff, especially post the NICE law settlement. So that's the focus there: hiring, training, rolling off our temps or converting.
And I just note that in the appendix, there is a slide that talks a little bit about the staffing glide path.
Can I just say that when you're using agency at the level we had to use agency, the skills and the ability to kind of integrate and get normal in that role takes time. So if they were long standards, we would see with the same people, less hours or whatever to get them up to speed. I would imagine.
Yeah, I think it's a great point, right? Our major themes were recruit, retain, and convert. And the convert part is we've had nurses that have been with us for a number of years, right? Over 900, right? That we could just convert from being a contract nurse to an H&H nurse. And we're proceeding with that, welcoming them in. We would love to have them.
Want to stay with us.
They would want to
You're
stay
looking
with us.
good.
Yes, it was. I mean, and again, I think we've had a great relationship with them. That's why they stayed for 2 years, and we're trying to kind of match salary packages. But I think we all believe, and nursing can obviously talk about this much better than I, but I think that continuity at this point, we don't want to lose.
That's right. Yeah. Thank you.
The nurse leaders throughout the department are very happy because one of the other problems is, if you think about it, how it affects morale of existing nurses if you do a job fair or a job posting and nobody applies. And everybody says, no, I'm not going to work for that salary. And now people are like, oh yes, this is a competitive salary. I'm interested in working at health and hospitals. So it's a huge, a morale lift for our nurse leaders who were really felt bad about having to so heavily rely on registry.
And it shows.
It would be interesting, we don't need to have an answer here, to get a sense of what the kind of average tenure experience, I should say, is of the new nurses coming in that we're now hiring versus the nurses that we've lost. I don't know if we're having more at the entry level, or we're able, with the salary increase, to attract more experienced nurses.
Excellent numbers for us to come back and share with you, right? Because I think we do, yes, if you're.
Well, I know it just because of some of the nurse leaders. The vast majority are new nurses, because that's how historically we've been.
Right.
And that's why John mentions retention is such an important part. But the nurse leaders have reported that for the first time in many years with the new salaries, we are actually getting experienced nurses interested in working with us, which we have not had in a very long time because of the salaries. Because many institutions won't hire new nurses, even when our salaries were poor, there was certainly still a market
Right,
of nurses who were interested in coming to get phenomenal training in the Lincoln Emergency Room for a year
Right.
and then leave for a markedly higher job. But, so we're hoping that with the new salary structure, they'll stay with us.
Terrific, thank you.
Salary and experience. When
Yep.
you have the right resources to do the job right, you stay.
So true.
It's great. Thank you.
Just a couple others, just the inflationary pressures. Obviously, the economy is grappling with inflation overall. We're taking a closer look. I think we reported 242 million off budget last year. Pharmacy is over 100 million within the 242. So, and we're again taking a closer look at that with Danielle. It seems to be mostly on the price side versus the utilization side. Maybe there are things that we can do to leverage better deals from pharma, so we'll look into that. City-state budget challenges, we always keep a close eye on that. The state reported, I think, a $9 billion gap heading into next year. It's a manageable gap, you know, for certain, but nonetheless, they're seeing some negative trends in their numbers, and we know the city's having budget issues as it relates to the asylum seekers and the costs there. So we'll continue to watch that, you know, through the fall. Federal budget, there was a question about the impact of the Medicare DSH cuts. Obviously, that was a fairly significant number, but I think on balance with some of the other actions that were in the IPPS reg, we feel like it's, you know, close to neutral, maybe somewhat little negative impact associated with that rule. And then we talked about Medicaid research. So it's a long list. I think we're managing it to the extent that we can, but we'll just keep an eye on these things.
Sally has a question.
Oh, sorry.
Yeah, I'm sorry, I jumped ahead on a slide.
That's okay.
Okay, I was listening too, but I jumped
Yeah,
ahead
that's
on the
fine.
slide.
You can ask your question now if you want.
There are two things actually, interesting use of EPIC, both on valuing the social determinants of health and looking to improve our acuity scores. I thought both of them were very clever.
You're on slide 16, Sally, is that right?
Slide
16.
16.
yeah, 16 and 17.
Yes, and the 3M vendor, right? Both of them are related. I don't know, Margie, do you want to go through? I mean, these are the technical things that we do, but are very important in terms from a revenue finance.
Yeah, very
Yeah.
clever.
Go ahead.
So on the social determinants of health, we worked with Revenue Cycle and the managed care team and IT the screening was happening. So people were being screened in primary care and other places for social determinants, but the codes weren't making their way onto the claims. So we worked with the EPIC team to automate the movement. If you see the screening, then it's documented and it can go onto a claim. So that really was the activity there. And you can see the jump in reporting, and we're tracking this very closely with MetroPlus, who has been a partner, tracking very closely, and you can see that we've increased the documentation and therefore the translation of the CRG, the social determinants codes.
Yeah, this work will only get more important in the future, right? Because both the state and Medicare are looking at Z codes to measure social determinants, and we appreciate that. We think social determinants should be looked at when you're trying to measure the needs of a patient, and it goes beyond just healthcare needs. So these are good trends for us. We think we're on the upside here, but I think there's recognition that there's more work for us to do, and it's coding work for the most part and educating our providers.
How much strength do we put into determining these determinants of health? Because in their different geographic areas, they're different and may be defined differently, and then it becomes standardized at the state level and is imposed. We have our own ability to say what are the strengths and weaknesses of these metrics.
Yeah, I will say, like, this is an all new area for the actuaries and the rate setting folks, right? And the nuances.
Slow then.
Yes, yeah, there's a lot of nuances here.
Too slow.
Yeah, it's too slow. Yeah, I would agree. I think I left the health department 5 years ago, and we were talking about it then. But it is good because I think in the future, both, CMS is signaling that these will be more important measures and they will work their way not only into reimbursement, but also into quality measurement. So we feel good about that. At least it's now getting recognition.
Let's start with our most high-risk patients,
Yes, absolutely.
medically and socially.
Yes.
Thank you.
Just on the VBP priorities, we can come back to these. I know Matt would like us to have a more in-depth conversation, but
Yeah.
we feel pretty good about the direction there. I would be remiss if I didn't say that for the 10th consecutive year.
Yeah,
our
the
ACO.
ACO.
If Matt's listening out there, Matt.
I wasn't gonna make you skip that page,
Yeah,
John.
yeah.
Yeah.
Can I ask a quick question on that one?
Yeah.
The quality metric went down, but they changed the measurement, and I was just wondering if how are we performing compared to other ACOs?
Yeah,
around the country when you
I
look at
saw that too, right? Because it's 92 right down to 75%.
75.
Yeah, we'll have to ask Matt and his team, I think.
Yeah, so I'm just curious about how it measures compared to other ACOs.
Yes, understood. Yeah.
Well, I think we can get maybe Matt to answer
Yes.
that. I mean, there is a note here that there's a new scoring methodology, so how did that impact things?
Yes.
Right.
Yes, and I'm sorry, I don't know the answer to that.
Certain scores don't really.
Okay, great.
Okay.
Yes, please.
Okay. Test and treat.
Next slide. Great. We're here to talk about our city initiatives. For Test and Treat, this is probably our final financial update, given that programming has ended, unless you really want us to talk more. Happy to be here. So from FY21 through the close of FY23, H&H incurred $2.94 billion in T2 related expenses. So that's your final update.
And then on the HERC side, H&H has incurred $468.8 million of HERC expenses for FY23. You can see this table breaks down kind of the different categories of expenses. So we have our contracted staff, those are vendor staff, security, medical, admin, things like that, as well as our H&H staff that support program administration. We have rent and cleaning of our hotel and congregate site spaces, food, site supplies, intake supplies, things like that, and then miscellaneous costs, which include things like mobile health vans, reticketing, training, and site setup supplies.
Any questions? Great. I think that,
Did it.
perfect, yeah, terrific. Thank you, team. I'm glad we didn't have to pass through anything. I know there's a lot more detail. We could talk about this all hour, but appreciate the good work. And let me see if there's any old business, any new business. There being no further discussion, the meeting is adjourned. Thank you.
This meeting is no longer being recorded.